Assalamu alaikum. Uh, Welcome to Imaging Study. Thank you for joining us today, just before the Eid holiday. And many of you are actually celebrating holiday, and many parts of the world will celebrate Eid al-Fitr tomorrow. So it's quite a holiday period going on. But before going to a long holiday, we just had a small time today. So we thought that we should actually arrange a session which will be very short because I always try to show you only 5 cases, which won't actually take much time. So hopefully for next few minutes, you will enjoy some of the ultrasound cases that I have got in my recent practice. Most of the cases are from last week practice, so you will enjoy what we actually enjoyed last week. So anyway, thank you for joining. Today, I am Dr. Mahin Ashraf from Bangladesh, and welcome to our today's session. We usually arrange this type of sessions on every Friday, but this Friday I was a little bit busy, so I need to arrange this thing later on this Saturday. So if you're new to our program, we have a YouTube channel named Imaging Study, which has already got around 480 videos. And we have fortunately got more than 63K subscribers, which is great because for an ultrasound based channel, this amount of subscriber is very uncommon, as we think. We just hope to get 20K subscribers, but we got 3 times more, so we are very happy about that. Anyway, we have uploaded our previous this type of sessions on our YouTube channel. So if you have missed them, you can just go and get them there. We also have many different abnormal cases there. So many of them may be helpful for you. So yeah, we also wish you Eid Mubarak. Let's start. Okay, so let's jump into our case number 1. So this will be a 23-year-old female patient who came with dysmenorrhea, and there was a left lower abdominal pain. Let's see what we have got on ultrasound. Okay, so here now you can see this is the uterus in a longitudinal section. Let me just do a little, just 1 second, please. It will take some noise. I found that the sound system has something error here. Okay, now it will be okay. So anyway, so here you can see the uterus. The picture is not quite good. I know this is for different reason, but I tried to measure the uterus. It looks quite normal for the measurement. Let's jump into the left adnexa. On the left adnexa, we can see round or oval homogeneous mass, or you may say it as a cystic lesion because you can see some posterior acoustic enhancement over here. So this cystic lesion is not anechoic. If you compare with the urinary bladder, this is the urinary bladder, this is anechoic. But in comparison to the urinary bladder, this structure is hypoechoic and it is homogeneous. So this round shape hypoechogenic homogeneous mass with fine low-level internal echoes is nothing but the endometrioma, or we can say it a chocolate cyst. Okay, so whenever you see an endometrioma, this is the typical endometrioma, and it goes in favor of URADS 2 if it is less than 10 centimeter in the longest diameter. So it's an URAD 2 lesion, and we'll use the color Doppler to see the color scoring. We couldn't actually differentiate the left ovary from this lesion. Possibly this part is the ovarian part. If you do a transvaginal ultrasound, you can easily see the part of ovary, but for the transabdominal ultrasound, it may not be much satisfactory. So let's change the transducer. We have used the volumetric transducer. It may give a little better resolution. Always, whenever we get a lesion or a pathology, we try to see it with different transducers. That sometimes gives us a little more information, like the heterogeneous texture or something like that. So we use the our volumetric transducer. Now you can see this homogeneous, fine low-level echoes within this cystic lesion. We are calling it cystic because there is posterior acoustic enhancement, and we know it's a cystic lesion. So let's see it with another view. Now you see this homogeneous structure here, and it looks quite homogeneous. If you check the patient on the 4th, 5th day of menstrual cycle, then you may get a heterogeneous texture with some anechoic or echogenic particles inside, which is nothing but the menstrual blood. So whenever you see tiny endometrioma, you face some confusions. You just rescan the patient on the 4th, 5th day of menstrual cycle, and with the change of texture, you may easily confirm it as an endometrioma. Now here we have put the color Doppler, and on color Doppler you can see there is no internal vascularity. If it was a mass lesion, there should be some vascularity, obviously. Let's put the transducer, the box a little bit far away from the margin. Now you can see the marginal flow here, and we are using the power Doppler, and you can see good amount of flow there. So these are the peripheral flow. If you check the pulse wave Doppler, then the spectrum may show you the ovarian or uterine arterial flow, which are actually supplying the surrounding areas. Okay, we have used the 3D and with the volumetric probe, you see we have chosen this part, this area, and the rendered image came like this. So you just edit the image, you change the view, then you may get this type of picture. Obviously, you can say that what will we do with this type of picture? This is a common practice that whenever you get a lesion, you get something abnormal, you should practice 3D on those images, because after 5 or 10 years, make sure we'll provide all the lesions with 3D images. That will get very common. Already it's quite common even in my country. So you should try to practice if you have the 3D probe. Okay, so the lesion measures around 5 centimeter in the long diameter or the highest diameter. So it's less than 10 centimeters. So we'll go for the URERS 2. And if you put the color Doppler or power Doppler, there is no internal vascularity, which goes in favor of color score of 1. So this is a case of left adnexal endometrioma, and we'll go for the URERS ultrasound score of 1 and the color score of, URERS ultrasound score of 2 and the color score of 1. Make sure you should always try to report it with the URERS scoring. Maybe it's may it differ from center to center, but in my center, we try to follow the URERS scoring. Okay, before going to the case number 2, don't forget to mention your location from where you are watching our content, so that we can enjoy and know the people and know the countries from where the doctors and the people are getting connected to us. Anyway, let's jump into the case number 2. So this is a 31-year-old male patient who came with a painful erection. Okay, so there was a cord-like palpable structure on the right side of the penile shaft. That took his and his doctor's confusion or attention. Then he was sent to us for an ultrasound examination. So we have used the high-frequency linear transducer to evaluate the penile structures. So here's the transverse section of the penis, and you can see this is not a very good view. It was just the primary examination. These are the corpus cavernosa, and this is the corpus spongiosum. This looks quite normal. There is nothing abnormal with the penile muscular or sinusoid structure. So the cavernosa and spongiosum are quite normal. Now, in case of a painful erection, always I try to evaluate the vascularity and especially the venous vascularity. Like if you see here, this is the superficial dorsal penile vein. So you'll see the penile vein thrombosis commonly in the patients come with the cord-like structures or cord-like feeling, that type of complaint. So in this case, the superficial dorsal penile vein is showing a very good flow, so there is no chance of thrombosis here. But it's not the end. We should search a little more. So now we are jumping into the transverse section. Let's see the surrounding area. So this is the right side where the patient was complaining. So we'll focus on this part. These are normal area. So let's look at this part. If you try, oh, here you can see this round structure. Yeah. There was a round structure over here. Let me just jump into this part. Look at this part. Just focus on here. Yeah, here you can see. Let me freeze the image. Let's go a little bit here. Yeah, you can see there is a round structure and it was palpable, and it feels like something hard over there. So that took our attention. What it can be? Is it a nodule or something like that? Patient complained about painful erection. In such case of nodule, we don't actually get a painful erection type complaint. So we want to focus a little more on that specific part. So let's look at that area on linear view on longitudinal section. Now here you can see a linear structure. I'm trying to compress, but it is not getting compressed. So this linear structure with internal hypo to echogenic content is nothing but a thrombosed superficial vein. So this tiny thrombosed superficial vein is causing the problem. And you may easily miss this structure, but this is the reason for the patient coming to you. And what vein actually is it? So this is actually the a superficial vein at the mid part of the shaft. If you ask me, this vein is nothing but the circumflex vein of the penis. So from the venous sinusoids, the emissary vein drain into these circumflex veins, and these circumflex veins drain into the deep dorsal penile vein. So it is very unusual to see only thrombus in this type of area, but it can happen, obviously. So let's jump into the view again. So this is actually the circumflex penile vein, which is showing the thrombosis. So you may easily miss this structure if you are not very careful. So let's see the image here. Now you can see this is the vein which is thrombosed on transverse and longitudinal section. It may be difficult. In my machine, the linear transducer is not quite good. This transducer, the smaller linear one, is very good for the Doppler scan, but it's not very good for the high frequency superficial structures. So the musculoskeletal type probes are quite better for these structures to identify. So here you can see this structure, and this is the thrombosed vein, and you can see without compression the structure is around 2.1 millimeter, and I tried to compress, it's not quite compressed. So this is a non-compressible circumflex penile vein. So here's the longitudinal section, and now you can see this thrombosed circumflex penile vein. Okay, so this one is the thrombosed one for this patient. Okay, so this is a case of thrombosis of the right circumflex penile vein, indicating the Penile Mondor's disease. So the superficial venous thrombosis or thrombophlebitis is commonly known as Mondor's disease, which is not very uncommon in our regular practice, but we usually miss this diagnosis. Okay, so whenever the patient comes to you with the history of trauma or during sexual intercourse or after sexual intercourse, severe pain in the penis, you should be a little bit careful. It may not be always the penile trauma. You may get the penile venous thrombosis. Okay, this is a holiday season going on. So during the holiday season, we commonly get this type of cases. It's very common. Okay, anyway, that's the physiological process. Anyway, let's jump into the case number 3. This will be an easy case, and the patient is a 76-year-old male patient who came with hematuria. Let's see what we have got on ultrasound. Here is the picture of the kidneys, because patient is coming with the hematuria, so we need to search the renal lesions. The right kidney looks quite normal. In my country perspective, we go for the 8 to 12 centimeter length normal for our body height and the BMI. For many parts of the world, it's 9 to 12 centimeter normal range. But for our country, 8 centimeters is very good because we don't need a much larger kidney to survive. Anyway, so this is the left one, which is also quite normal. Ignore my poor quality image. There are two cystic structures, which are the renal cortical cysts, which is common finding, but this should not be the cause of the hematuria. Let's see the urinary bladder. So here's the picture of, oh no, this is the liver. Why I'm showing you the liver? There was a tiny finding here. You can see tiny echogenic structure, some casting post-acoustic shadow. These are very tiny structure, so may not cast shadow. So these are the hepatic calcification or calcific foci, which you may commonly see or commonly miss. We commonly see it on CT, but sometimes we miss it on ultrasound. Ignore that. Let's jump into the urinary bladder. Now on urinary bladder, it's quite partially filled. Patient couldn't feel more. He complained about pain and difficulty. So we checked him, and the bladder wall was slightly thickened, but for this partially filled urinary bladder, it's very difficult to say. So we need more filled bladder to say it a thickened bladder wall, because in thickened state, in filled state, you may see the wall getting thinner. Anyway, let's jump into the lesion. So here, make sure the prostate was normal for this patient. We're not showing you that image. So here you can see something abnormal here. You can see this is not the prostate. So this is something within the urinary bladder lumen. We need to evaluate it. My net connection is getting a little bit jumping, I think. Okay, so somebody is trying to call me. Anyway, so here you can see that, yeah, it is getting just paused. Okay, just let me see. Okay, now it's okay. So here on this image, you can see I have changed the transducer to the volumetric one, and you can see there is a mass-like structure here. It is a heterogeneous echogenic mass-like structure coming from the left side, left urinary bladder wall. So this lesion is protruding into the urinary bladder lumen. And as the patient is elderly, so this should be thought as a transitional cell carcinoma, which is very common in our community. Okay, so let's see it with different preset. Now you can see this lesion here coming from the left lateral wall of the urinary bladder and protruding into the lumen. So this is a urinary bladder mass, possibly malignant one. Here we try to measure the lesion. We use the power Doppler here, but there was no prominent vascularity. Make sure your ultrasound machine may make you confused. So usually transitional cell carcinomas are highly vascular or may show you a good amount of vascularity. But here we couldn't see any vascularity. Possibly we missed it. Okay, so we use the 3D to evaluate the lesion. Now, when we rendered the image, you can see we got this type of image. So from this image, this one is the mass. This is the mass area within the urinary bladder lumen. So let me just adjust the image a little so that we can get a good quality 3D picture. So we check the image like this. We took the tomographic ultrasound imaging. And now on tomography, we have chosen this type of slicing. And now you can see the lesion is coming out from the left lateral urinary bladder wall. So this is a urinary bladder mass. So rendered it on a different view. And now you can see this is the urinary bladder mass on 3-dimensional ultrasound image. Okay, so this is a case of urinary bladder mass, possibly the transitional cell carcinoma. we should be diagnosed with other histopathological evaluation, obviously. But these are usually transitional cell carcinoma. Okay, now let's jump into the case number 4. This will be a small case, obviously, and the patient is a 15-year-old male patient who was diagnosed as a case of cholelithiasis. Okay, this is a very common case in my practice, so I thought that I should actually share this case with you. This patient was diagnosed as cholelithiasis several times on ultrasound. Okay, I'm not actually telling it wrong, but when you get a patient with as a child, like 5-year-old, 10-year-old, 15-year-old, this is very uncommon age for cholelithiasis. If you see the patient having cholelithiasis, you should think about some differential diagnosis, like it might be a thick slash. Okay, take the history of high fever, take the history of using broad spectrum antibiotics or something like that. Okay, this patient had no history like that. Okay, so check the patient having any metabolic disease. So the patient, my patient had no metabolic disease, so ignore that one. So now let's jump into the main cause and common cause in usual tropical countries. So here is the picture. You see, this is the gallbladder. If I show you the case, you see tiny echogenic structures casting posterior acoustic shadows within the lumen. So 100% or even 99% of people will say it as a cholelithiasis. Okay, I appreciate your diagnosis. This is calcified structure, so you should say it as a stone, but you should be more sophisticated to make the diagnosis. You see this part. This part is casting post-acoustic shadow. This one casting shadow. This one casting shadow. But this one is not casting any post-acoustic shadow. So why this part is not casting shadow? Yeah, you may say that no, it's a little bit shadow here. Okay, let's see the video. So now I'm using the linear transducer to diagnose this case. So on linear transducer, can you see any shadow here? Yeah, you may say I am just looking at some faint post-acoustic shadow, but you see the appearance has got changed now. Uh, this area, you see some linear-like appearance, and there is no dark shadowing here. So let me freeze the image a little. Um, if I don't want to make it a fragmented one, just draw it like this. So it's like this type of appearance. So just let me draw a little bit. I'm not good in drawing, obviously. If I show you this structure right now, it doesn't look like a stone. Rather, it looks like a dead worm right now. So this structure is not the calculi, rather these are actually fragmented dead worm which are getting calcified. So the dead gallbladder worms will get calcified over time. So this is not the calculi. Rather, you should report it as a dead calcified or partially calcified worm. Okay, so this is the worm. You should know that exact thing that is going on over there. Why the patient is having a calcific structure within the gallbladder at this age. So you should think about worm, especially in the countries where the helminthiasis is not very uncommon. Okay, let's look at another image. So here you can see these are parts are the calcified one, but here at this end there is no vascularity, no post-acoustic shadowing, and the end is slightly tapered. So this is the end of the worm. So make sure whenever you get a young patient or a baby having cholelithiasis, you should use the linear transducer. With linear transducer, you may see a folded worm-like a structure within the gallbladder, which may get confused on curvilinear transducer as cholelithiasis. Okay, so here on curvilinear transducer, you see the calcified fragmented structure, and you see the end area. So this is the tapered end, which is the end of the worm. So this is nothing but the dead calcified worm. Here's another view. You see now, this is not fragmented. This part is not fragmented. This is a continuous part here. So this is the tail or head of the worm. Okay, so you may say it a calcified structure. When you open the gallbladder, you may find some calcific structures over there. You may say it a stone. Okay, so this is stone-like structures over the within the gallbladder, but this is due to the death and calcification and fragmentation of a worm. Okay, so this is the fragmented dead worm within the gallbladder. So the end diagnosis is definitely the calcified and fragmented dead worm in the gallbladder. Okay, so don't get hurried to diagnose a case as cholelithiasis. Whether you always should try uh, to say something different in case of cholelithiasis. That will make you expert. Okay, let's jump into the case number 5. So this will be the last case for the day, and obviously it will be a pregnancy case. In my last week practice, I was totally depressed because I have seen a lot of pregnancy cases. Usually in my chamber, I don't usually like to see the pregnant cases because sometimes patients are sent to me for the diagnosis of congenital abnormalities, and I feel very discomfort because the patients get worried, patients cry sometimes because the baby won't survive. So I just want to skip that part. I want cool patients. But unfortunately, last week I had to face so many pregnant cases, and unfortunately, most of the patients won't celebrate Eid for this week because I don't know why my cases were so much complicated this week, and most of the cases came with congenital abnormalities. I don't know why. Okay, so one case for the day. This is a 25-year-old female patient who came with amenorrhea for 6 months. She gone through a congenital abnormality scan, which was normal, fortunately, but there was a history of congenital heart disease for the previous child of this patient, and the baby died on the fourth day of birth or after 3 days, whatever you say. So the patient was repeatedly advised for fetal echocardiography. I checked the prescription of the doctors. So they all, like 3 or 4 times, she was advised to go for the fetal echocardiography. I asked them whether there was a normal anomaly scan report or anything abnormal there. So she said that the anomaly scan report was quite normal. So let's see what we have got on the fetal echocardiography in this patient. So there's the measurement. You can see it's around 24 to 25 weeks of gestation, which is okay. I'm not having any problem with that. So when I started, the position of the baby was not very suitable. So you see the heart is apex is downwards or looking posteriorly. So it's very discomfort to see the patient like this, and you need to wait to see to get a good view. That is quite disappointing whenever you're practicing fetal echocardiography. Anyway, we waited for a while, and fortunately, the baby moved a little. Now we are getting a good view here. You see the three vessel view over there. Let me freeze the image from this part. You see, this is the three vessel view. This is the pulmonary trunk. This is the aorta. This is the superior vena cava, trachea at this part. This is the thymus of the baby. These are the lung parenchyma over here. So we just move the transducer a little. Now you can see the pulmonary artery. This is the pulmonary trunk coming here and getting branched. This is the ductus arteriosus draining into the aorta, descending aorta. Okay, so let's move the probe a little. Okay. Don't be hurry a little. So here's the LVOT view, not the good view, but it was normal, trust me. You see, this is the interventricular septum. So it is continuous with the aorta. There is no VSD at this part. So just look at the four chamber view from this image. The four chamber view apparently looks quite normal, no chamber enlargement over here, and the interventricular septum looks quite normal. Okay, so up to this poor quality image, the patient looks quite normal. Okay, we are not satisfied. Obviously, if it is normal, I should not show you. Anyway, let's use the color Doppler over this image. So now when we are using the color Doppler on a four chamber view, we are not satisfied. Now you see the flow, the inflow, obviously, but if you look at the interventricular septum, you continuously see the flow over here. You see there is a flow. Yeah, there is a flow here. So you may miss it with the regular transducer or B-mode scan, but when we are using the Doppler, uh, just let me move. Yeah, now here we can see a flow over the interventricular septum, the muscular part. So let's look at that part a little bit carefully. Now we are focusing on that part, and we still can see we want to ignore this finding, but we can't actually. So we are watching it here. If you see the grayscale image, you may miss that because if there is a prominent gap, you may easily see that. But if let's think that this is the interventricular septum, if there is a gap at this part, so you may not see on grayscale. Like on grayscale, if there is a gap in this part, you will see that. But if it is on the middle part, you may miss that. So if you put the Doppler, then there will be a flow from this middle part, so you can easily detect it. So we only can see this flow on Doppler, but there is no gap on curve on the B-mode or grayscale images. So this is the gap that took our attention. We measured the flow. Obviously, it won't be very accurate for the measurement because if you change the PRF, if you change the gain, the thickness of this flow will get increased or decreased. But it was around 1.8 millimeter thick. Okay, very tiny one. So let's see it from different angle. Try to ignore this one so that we can report it as a normal one like before. So now we can still see. Now the question arises, is it an artifact or is it it is definitely a flow? How can we confirm? So if you see, this is the solid part over here, interventricular septum. If you put a pulse wave Doppler, as this is a shunt usually has a very rapid jet. So if you put a pulse wave Doppler, you'll get a rapid jet. Firstly, to avoid confusion, you should put a pulse wave Doppler over this area and this area, like on the mitral and tricuspid area, so that you can understand which one is the mitral flow, which one is the tricuspid flow. Then you will put the pulse wave Doppler over this flow so that you can differentiate among these other flows. Okay, we'll see that. But before that, let's jump into other views. We are just changing here and there to ignore that flow, but still you can see this interventricular septum showing a flow over here. Okay, so here again, we're changing the PRF and color gain and everything to ignore this flow, but now you can see it quite well. Okay, so what we can do else? We can use the 3D here. 3D is an excellent one to evaluate this type of tiny ventricular septal defect. So let's jump into the tomographic ultrasound imaging. So here we have just taken a 3D image or 4D image, whatever you say. We have chosen some area. Now you can see these are the three vessel view, the crossing of the great vessels, which looks quite good. Okay, we are going here. You can see this is the LVOT view, left ventricular outflow tract view, and now you can see this interventricular septum is showing there is a tiny flow over the interventricular septum here and here, and a tiny bit of here. So definitely this is a case of ventricular septal defect. Let me freeze the image and show you this is the ventricular septal defect. You can see flow crossing from the interventricular septum. So here's the flow, here's the flow, and here's the flow. This is the flow of the interventricular septum. Can we use different 3D modes to show you this image again? So we have the omni view or multi-sectional view, so many type of different views. So here we are using the multi-sectional sum view. Now you can see we are just showing you this picture, and you can see this VSD, the flow through the interventricular septum at this part. Let me select this area, the VSD area, with the omni view option on the G machine. So I have chosen this area. I want to look at this part on a different section. Now on different section, you can see this is the interventricular septum, and you can easily see the flow. So there is obvious flow through the interventricular septum, and nothing more is needed to confirm this as a VSD. Okay, so we are using multiple approaches to diagnose this thing. As the patient already had a baby with the cardiac abnormality, so we just need to confirm it, because it will be beneficial for our clinician on as well as for the patient. Okay, so this is the VSD. Now you can see on Omni view, and it's quite clear now. Okay, so this is the tiny VSD, and it was around 1.8 millimeters, so very tiny one. We need to go with a follow-up after birth. There was no other cardiac defects, fortunately, so make sure you should be careful to evaluate the pulmonary trunk, because if you see the pulmonary atresia in this such case, you should think about the phallostetrology, obviously. Okay, so let's put the pulse wave Doppler in this patient. So we have put pulse wave Doppler just at the interventricular septum. Now you can see a very high peak of flow of more than 80 centimeter per second through the interventricular septum. So this is the VSD flow over here. And now you need nothing more to confirm it as a VSD. So we have shown you on 3D, we have shown you with the pulse Doppler, the flow of the VSD, and obviously you don't need anything more. Okay, so an extra part. So during a scan, this patient had a very good abdominal view. So let's show you the technique to understand the ductus venosus, because many of you complain about searching for the ductus venosus. So here is the regular abdominal circumference view, where you see the umbilical vein entering into the abdomen, getting connected or continuous to the left branch of portal vein. Okay, whatever. You see this is the abdominal aorta, this is the stomach, and this structure is the inferior vena cava. So inferior vena cava and the umbilical vein will get connected through a tiny channel, which is called the ductus venosus. So you see a tiny anechoic bridging here. This is the ductus venosus. You are not getting clear view. So just put the Doppler here. So when we put the Doppler, make sure you're seeing so many flows over here. The lightest one or aliasing showing one should be the ductus venosus in an abdominal circumference view. So if you look at this image, you see this part of the abdomen is showing aliasing mixture of color, or you may say it the lightest color. So this lightest color area is the ductus venosus. So just put the pulse Doppler over here, and then you will get this type of flow in this area. So whenever you make a view of the abdominal circumference, you should put the Doppler, and you should see the aliasing or lightest color area. Just put the pulse Doppler over there, then you will get this type of good flow of the ductus venosus. And it's quite easy technique. Okay, so this was a case of 24 to 25 weeks of single live intermittent pregnancy with a fetal ventricular septal defect. Okay, that's all for today. So thank you for joining me, and this video will be uploaded in our YouTube channel tomorrow. So don't forget to check that if you have missed the first part or something like that. And obviously, we'll keep this video on our Facebook page, but Facebook will delete this live session after 30 days. So then we will try to upload again. Anyway, so you can easily get these lectures on our YouTube channel. Anyway, and you can also visit our imagingstudy.com, though we are very irregular on that part. And it doesn't matter from where you are joining us or from which religion you are getting connected to us. So we wish you all the Eid Mubarak. May Almighty bless you all. And hopefully the holiday season will be very enjoyable for you. And yeah, so tomorrow there will be Eid festival in many parts of the world. For my country, we'll celebrate Eid the day after tomorrow, I think. So we'll wait one more day, actually. So anyway, wish you all Eid Mubarak. So thank you for joining us today, and hopefully we'll make a break. And our next this type of session will be, just let me check. Our next session will be on 12th April. Okay, so after just 1 week break, because the next week I won't be in my country. So I have planned for a small trip to any part of the world. So I won't be available, and inshallah. So the next session will be on 12th April, hopefully. So thank you for joining. If you have any question, you can just put that down on our comment section. I'm just looking at the live session, not looking at any groups where I have already posted this video link. Okay, so many people are joining from different parts of the world, which is actually interesting and enjoyable, because it's a very good way to get connected to the different parts of the world where in my lifetime I may not be able to visit, actually. So anyway, thank you for joining us today, and hope to see you all in our next session. Till then, thank you. Eid Mubarak. See you on the next one. Have a nice day.